Yeah, one, sorry. Okay. So let me see if my whiteboard shows up here. It's my first time doing this, so can you guys see my whiteboard? I'm gonna draw something. Can you guys see that? Is this-
Yes.
Oh, look at that. Sorry. Okay, so can anyone call out so we're gonna assume the diagnosis is correct, right? We're gonna focus on diagnosis in 517. Someone gets diagnosed with MDD or unipolar depression. What are some classes of medication that we would offer them? What is the first line that everyone always gives? What is it called? Four letters,
SSRIs.
right? So SSRI. So I'm gonna make a category for that. Okay. What's another class of medications that we use for unipolar depression?
Would it be
NSRI.
SNRI, right? So serotonin.
SNRI.
Yeah, very good. So that's going to be the next column. SNR.
All right.
Now, this med wasn't used first line before, but there's a lot of guidelines now that are actually causing people to use it more often because it causes less side effects and doesn't cause the weight gain of a lot of the other antidepressants. It's in a class of its own right now. What is the class of it? It's a,
Would it be the tricyclic
not yet.
antidepressants or no?
It's a
Talk about Wellbutrin.
DNRI, Wellbutrin, right? So I'm going to try to break it down easy so you get the classes DNRI. Okay. And someone said tricyclic, right? TCA, which we don't really use first line, but I sometimes use it. And what's the other one? What's another one? That everyone's afraid to use, but I use it a lot.
MAO, the MAO inhibitors.
MAOI.
Right, good. And we do have some like newer meds, and I'll list them here. We have Spari, SPARI, which I'll explain what that means later on. We have NASA, NASSA. You have NMDA antagonist, right, which is a little bit newer too. Right, and we also have interventionals. I'm not going to talk a lot about interventionals because that's going to be its own thing, especially when you guys move on. We'll talk about that. That's when people kind of don't respond to the regular meds. So SSRIs, right? Can anyone name me, some common SSRIs that you see? You can give me the brand name, the generic. I'll write both in there.
Sertraline?
Sertraline. What is that called? What's the brand name of it?
Is it Zoloft?
Zoloft.
Give me another one.
Escitalopram. Escitalopram, which is Lexapro.
Paroxetine.
Very good. Paxil, paroxetine. Another one. Give me another one.
Fluoxetine or Prozac.
Good.
Fluvoxamine.
Very good. So fluoxetine. What was that? Sorry if my handwriting is not that great. And fluvoxamine. Excellent. All right. I'm gonna break down the SSRIs now. I'm not. It's gonna take too much space, but I want just to be like your overall. So if you guys have a pen and paper, which I said bring a book, I'm gonna give you guys details about the SSRIs, right? So anyone here want to do child psychiatry? I did many years of child psychiatry too. So for all the child psychiatrist people there that want to do child psych, all right, you probably would leverage two medications that have the most evidence in child psychiatry, right? That's fluoxetine Prozac, right, which is FDA approved as young as age 7, right? And you have escitalopram Lexapro, which is FDA approved as young as age 12. Doesn't mean you can't use it younger, but the evidence just shows it was approved for that age. So I would probably try to keep that guideline for now. And if it doesn't work, then of course you can always escalate. So just quick review for child psychiatry, Lexapro, escitalopram, and fluoxetine are really the two most leveraged medications, all right? Now, for adults, we tend to use sertraline a lot. Now, one of the reasons why I use sertraline also, especially in older adults, geriatric adults, is because sertraline doesn't have as many drug-drug interactions, especially with cardiac medication, right? Beta blockers, angiotensin receptor blockers, you name it. It doesn't have that many interactions with that. As opposed to fluoxetine, Prozac, which I'm going to emphasize this again, is a very potent 2D6 inhibitor. 2D6 inhibitor, right? And also can inhibit 3A4 as well. The problem with that is if someone's on a beta blockers are metabolized by 2D6, it's going to increase that dose of that medication, right? And all the other medications. So 3A4, 2D6, 3A4, and a lot of medicine, is metabolized by that. So it could affect a lot of other medications. So I try my best not to use Prozac on adults because it just messes up the regimen for a lot of all the other medications. If a patient's stable on the regimen and they're on Prozac, right, I'm not going to touch it, obviously, right? But if I anticipate they're going to be in other medications, Prozac might be, a problem later on. So I try to wean it off. Now, there was a question on the exam that I asked, what would be the highest risk for drug-drug interaction, if you guys remember? And some of the answers were short half-life, right, and weak inhibitor. Another answer was long half-life, strong inhibitor. So which one causes the most drug-drug interactions? After what I just told you, fluoxetine, right? It's a long half-life medication, right? About a week. It's a very potent 2D6 and about a moderate. Some books say potent 3A4, but some say moderate, so it affects 3A4 as well. So just be aware that Prozac could be a problem. Now, I'll give you a case study. I like to give examples with patients because sometimes you can visualize it, it'll make more sense to you. So I had a patient that came to me, child psychiatry, and the mother was like, the kid was on a medication prescribed by the PCP and, they added Abilify and the kid got really aggressive. They couldn't sit still, they were moving around. And, when we talk about antipsychotics later, they can cause something called akathisia, which is restlessness, right? That's usually caused by antipsychotic medication like Abilify. Abilify is it's primarily metabolized by 3A4 and 2D6. So what happened was, even though the patient was on Prozac, the prescriber didn't know that the Prozac was still in the system because it takes about a month to wash out, right? So imagine, even if someone said, I'm not on Prozac anymore, you need to find out, when was the last time you took that Prozac? It's very clinical program. Ask the patient or ask the parent, when was the last time they took Prozac? Because then you can estimate a washout of about a week, right? And it's also important because if you're going to switch someone from SSRI to a monoamine oxidase inhibitor, and you don't do that washout period with Prozac, right, you can kill the patient, right? Because it's going to cause serotonin toxicity. Because they're going to have the Prozac in the system, still the serotonin is going to be there. You give them a monoamine oxidase inhibitor. What is monoamine oxidase? Monoamine oxidase is something that breaks down excess neurotransmitters, right, inside the neuron. So if you don't have that enzyme there because you're inhibiting it with the medication, your neurotransmitters are going to be very high, right, and cause side effects. Now, I'm going to stop there for a second because that was a complex concept. Do I need to slow down and clarify what I just said?
I just have a question. Did you mean a month washout period or a week?
A month washout period.
Okay, I think okay, thank you.
5 half-lives is the washout.
Can you go over, so wait, so you were saying for the SSRI, if you're going to switch a month washout?
Or Prozac.
Prozac.
Yeah.
Do you mind, well, when we ask questions, never mind. Go ahead.
Now, Prozac is risky, but doesn't mean you can't use it. The good thing about Prozac, it tends to be more energizing than a lot of the other SSRIs, right? I know they're called SSRIs, but they have minute details in them, all right? Even though they're majority SSRI, some of them hit other receptors also. I'll give you an example. Prozac is a decent norepinephrine reuptake inhibitor also. It does hit net. If you look at the stall book, it's going to say that also. So the significance of that is it increases norepinephrine a little bit, so it tends to be activating for some patients. So they tend to have a little more energy, and Prozac tends to have a little bit less weight gain than a lot of the other medications, right? Because it's more energizing, right? It also hits, obviously serotonin. It also hits something called the sigma receptor, which we're still trying to figure out what the sigma receptor does, but it might have a special property with it, right? Sigma receptor. So Prozac, definitely know, potent 2D6, 3A4 inhibitor, very long half-life, has a lot of drug-drug interactions, but has a lot of studies in child psychiatry, all right? Going to Lexapro now, escitalopram. I'm bouncing around, but you guys can just write it down, because it's better to compare it this way, and I can fill in details later on. Escitalopram has another isomer, citalopram, which is called Celexa, which I forgot to write there. So let me add that in there, Celexa. Citalopram.
An enantiomer.
Yes, and they're mirror images of each other. Now, it's interesting because I was watching a lecture and one of the psychiatrists said, and I agree with him actually, that it used to be that because they're isomers, they're similar enough that if someone's been on one, you shouldn't try the other. But I've seen patients and their history, and me myself, switched them from Celexa to escitalopram or vice versa, escitalopram to Celexa. And for whatever reason, it worked with the patient, right? So I can't explain that. I don't know, in the textbook, even though they're very similar, but it happened. So I think it's worth a try. So if someone, says, hey, Celexa works for me, but escitalopram didn't work, don't tell the patient, well, that's probably placebo because they're very similar, right? You're not going to say that to a patient. Consider it, but it'll work. Now, the main important about Celexa and escitalopram is that they can cause QTC prolongation, right? The QT interval is going to be prolonged, which can lead to cardiac arrhythmias later on, right? Torsades de pointes. So normally, if someone's at a very high dose, let's say above 20 milligrams of escitalopram Lexapro, we recommend EKGs at least yearly, all right? Probably more frequently if they're on other meds that also cause QTC prolongation, right? Like hydroxyzine. That also can cause very potent QTC prolongation. So you probably do it more frequently, right? If anyone has any, I don't know, electrolyte abnormalities, hypokalemia, hyperkalemia, any of those electrolytes, they can also cause arrhythmias. That will probably put them at risk also. I'm giving you guys excess information. Do as you will. It's up to you. I always give extra anyway, just for your own clinical, Now, but the important things that's important to know is that escitalopram and Celexa are one of the cleanest SSRIs. Cleanest in that they only hit serotonin reuptake pumps. They do not hit norepinephrine and do not hit dopamine, all right? And they have very little drug-drug interactions. They're not inhibitors at all. They don't inhibit any CYP enzymes, right? Sertraline usually doesn't, but if you go above 150 milligrams, which we sometimes do when we talk about anxiety and OCD later on, it can be a potent 2D6 inhibitor, sertraline. So just be aware of that. So if you start going 150 or higher for anxiety or for OCD, sertraline could affect 2D6 medications, all right? That's important to know. But sertraline is good in that if someone's on cardiac meds, it tends to be one of the safest, right? There's a lot of studies that show that. And sertraline is not just a serotonin reuptake inhibitor. It also has that is a dopamine reuptake pump also. Not as potent as Wellbutrin, but significant enough that it might help with focus in a little bit, all right? Questions so far. Key points: Prozac, long half-life, very strong inhibitor. All right, Celexa and escitalopram, cleanest SSRIs, are not inhibitors and they're only serotonergic. All right, but at high doses, 20 milligrams of Lexapro or higher, we recommend EKGs regularly, and with Celexa 40 milligrams or higher, citalopram, regular EKGs as well due to QTC prolongation. All right, yes, Madison.
Sorry, is there a chance you could just talk a little slower?
Sure.
Thank you.
Sorry, it's a lot of material.
Can I ask a quick question?
Yes, question. Yeah.
For sertraline, if you have a patient who's either like has any sort of a history of psychosis, like how strong of a DAT interaction is that? Like, could you increase dopamine enough where they did have an issue?
I have never seen it with sertraline, but I have seen it with Wellbutrin. There's case reports about that, so I would be careful with Wellbutrin. Sertraline, I haven't seen it, but maybe you can look it up and see if there's any case reports about it. But I've never heard of that. But that's a good point, right? Yeah, because you're increasing dopamine. Okay. Paxil, paroxetine, is the opposite of Prozac, right? That has a very short half-life, the shortest half-life of all of the SSRIs. Prozac has the longest half-life of all the SSRIs. Paxil has a lot of antihistamine, anticholinergic, right? So sometimes people used to use it a lot for anxiety, right? Because it's really the antihistamine, anticholinergic that's calming the patient down. We tend to give it for sleep, right? The other problem with Paxil is it's a nitric oxide inhibitor. So if you guys know what nitric oxide is, it's a gas in your body that actually causes your vessels to dilate, right? Specifically the vessels in your penis. So if you give someone Paxil, don't prescribe it to them a month before their honeymoon. You're gonna ruin their day. You're gonna piss them off. Paxil causes the most side effects, causes the most weight gain, and it's also a potent 2D6 inhibitor. But it's not as significant as Prozac because it's a short half-life. So once they stop it, it washes out fairly quickly. All right. Unlike Prozac, it stays in the system, so it's significant. Questions? Now, any questions at all? Sure.
In the reading of Stahl when we were doing in that section with SSRIs, it talks about how they think the effect is more on the dendrite side of the presynaptic neuron.
Great.
I just wasn't able to really understand from the reading like why that would be.
It's great. Actually, that was actually what I was going to talk about now, mechanism of action of SSRIs, right? So
Okay.
I draw it very slow. So this is presynaptic neuron, right? And that's the terminal. This is a postsynaptic neuron. So, right? You have the dendrites over here, right? And these little dots are actually the neurotransmitters, right? Now, the presynaptic neuron, I asked the question in the first exam, has something called an autoreceptor, right? Which normally shuts down the release of serotonin, right? It's a way to prevent autotoxicity. So you have these little receptors here, which are scattered around these little dots, right? One is 5-HT1A, which we talk about the most common, but is also actually 5-HT1B and 1D. You're going to see when we talk about atypical antipsychotics, there's actually going to be some meds that are blockers of those receptors as well that have some antidepressant properties, right? But we're going to talk about 5-HT1A right just now, all right? So there's the one, 5-HT1A. So initially, right, when you block the reuptake, it's going to stop those little dots from going into the presynaptic neuron, right? Initially, the serotonin is going to bind to the 5-HT1A receptor, which is an autoreceptor, which is a brake, right? So what happens when you innervate the brake? It's going to shut down the release of serotonin, right? So you wonder why I want to increase serotonin. Why am I, hitting the brakes? But the concept, what I told you guys the first exam, which I expect you guys to remember, at least we're going to go back over and over that, is the concept of down regulation, right, and desensitization. So initially, that 5-HT1A receptor is going to get hit with the excess serotonin neurons, right, that are being inhibited by the reuptake pump. Over time, maybe over 4 weeks, maybe over 2 weeks, it's going to start down regulating. Eventually, it's going to shut off. It's not going to work anymore. It's not going to be sensitive. So what's going to happen? There's going to be free flow of that serotonin in that synaptic cleft, right? This little area over here, synaptic cleft, by the way, so you know, that's the cleft where the magic happens. And that's what's going to cause the effect of the antidepressant properties, right? That's one of the postulations. I mean, we can't prove it, but that's one of the hypotheses of why it takes so long. Questions, thoughts? All right. Another.
Where does the upregulation of the BD and F come in with this?
Explain that also. That's another downstream. So remember, there's upstream and there's downstream effects, right? So downstream, after that cascade, the G protein, you talked about GSK and all that other stuff last time, right? But after all those cascades happen, it's going to cause your postsynaptic neuron to secrete brain-derived neurotrophic factor or growth factors, which is going to cause these connections here, right in the middle, to kind of spread out. It's called dendritic arborization, right? Another term for it. Dendritic is those are dendrites, right? Arborization is when a tree starts to sprout leaves, right? The way I explain it to patients is that they've been on numerous SSRIs in the past, right? Say they come, because if you guys don't know, I specialize in treatment-resistant depression now. I used to do treatment-resistant schizophrenia before that. But when patients come, they've tried all these meds already. So I explain to them the reason why you want to do NMDA antagonism, we want to do interventional, is they're rapid acting, number one. And number two, they increase the growth of your dendrites, right? By giving someone IV ketamine, giving someone Spravato, transcranial magnetic stimulation. The idea behind that is that it's going to increase the dendritic arborization, right? The connections are going to increase. So therefore, the meds will respond better, right? I've seen that also. Patients get something called like Prozac poop out. Sometimes they call it fluoxetine poop out, where they've been on it for many years and the meds just don't work anymore. So they come to me, we give them a short course of, IV ketamine if they can afford it, or TMS if their insurance covers it, or Spravato, which is ketamine nasal spray, right? It works pretty quickly, they get benefits, and they continue on a maintenance treatment of their SSRI, SNRI, or whatever they're taking. Does that make sense?
No. What does the ketamine do? You lost.
Oh, we're going to talk about the antagonist, right? That's another mechanism. Talk about that later on.
That helps with.
It helps with
the
causing your body to secrete growth factors, which will increase the connections, right? Because think about it. You might be increasing the neurotransmitters, but if there's not enough receptors because the dendrites are dead, quote unquote, right? Because they're not connecting anymore. The best way to get the connections starting up is by giving them a way to increase growth factor, right? One way to increase growth factor is by giving someone an NMDA antagonist. I'll explain the details about that once we get to that point.
Now, do you keep them on the SSRI or you take them off, go through?
Normally you do. Guidelines will say yes, because the thing is, even though interventionals work fast, they don't have a very good, they don't have, it's called durability, right? Another way we explain how long does a treatment work, it's called durability. How durable is the medication? It's not durable because sometimes it lasts a week, sometimes it lasts a month, but it's still better than nothing, right? If someone's been suffering from depression for 10 years, even a month of not feeling depressed is a big thing, right? So I'm
Yeah.
yeah. Joseph, question.
Yeah, sorry. I just want to make sure we're on the same page. Like, the SSRIs work because they are basically overstimulating the 5-HT1A autoreceptors, which causes a kind of desensitization to pulling back the production of serotonin. The serotonin starts getting pushed out of this presynaptic cell.
Yes,
And
that's the basic way of explaining it. Now, the reason why sometimes it doesn't work is, if you don't know already, there's about 16 different serotonin receptors, right? 5-HT1A, 1B, 1D, 2A, 3C, 5-HTC. I mean, I can go on, right? 5-HT7, 5-HT9. There's so many of them, right? Now, the problem with that is that when you increase serotonin, right, it's going to bind freely. Like I said, the same issues we have with all the other psychiatric medications. It's going to bind to inhibitory serotonin we don't want it to bind to. It's going to bind to excitatory serotonin receptors, which you might want it to bind to, right? It's gonna hit all the serotonin receptors. That's what might downregulate dopamine, causing apathy, right? That might downregulate your sex drive, which causes sexual dysfunction. It might hit a serotonin receptor that's implicated in weight gain. The serotonin receptor is implicated in suicidal thoughts. You see where I'm going there? We can't give a med that's very targeted with SSRIs. That's why the newer meds, which I'm going to talk about later on, not only are they serotonin reuptake inhibitors, but they also have serotonin antagonism at specific serotonin receptors to kind of make it a little bit cleaner, right? Does that make sense? Clear? That's why it's so difficult sometimes with a broad, think of antibiotics, right? You can give someone a broad spectrum antibiotic and you'll kill a lot of bugs, right? But what about the good bacteria? People get a yeast infection, they get, diarrhea, they get all these other side effects that you don't want because you're targeting everything. And that's not always the best approach. All right. So yes, question.
So most people on SSRIs are definitely on an adjunctive therapy too, then, because it's just such a broad medicine that you gotta
Yeah, that's why sometimes SSRIs by themselves are added. Are not by themselves. We add specific meds to be very specific with the treatment. All right. So that's the downside of SSRIs, is that it's broad spectrum and that sometimes people are more sensitive. Now, going back to epigenetics, they said the first lecture, some people have a short, they have not a lot of serotonin reuptake pumps, right? They have a long gene. They might have a lot of serotonin reuptake pumps. They might have adverse childhood experiences. They might be more sensitive to specific serotonin receptors. Remember, our body will create receptors based on our genes, right? Based on genes awakening, based on epigenetics. So, based on those receptors, some people might be sensitive to certain receptor profiles being innervated than others, right? But we can't tell right now. We don't have biomarkers. That's the tough part. So remember, if I ask you guys in an exam, why does it take an SSRI to take so long to work? The answer should be, paraphrased obviously, it's downregulation of the 5-HT1A autoreceptor at the presynaptic neuron, which is going to take time to happen, right? Also, that's one of the effects. It also is going to hit, of course, serotonin is going to hit the 5-HT2A receptor. What is significant of the 5-HT2A receptor at the postsynaptic neuron? Psychedelics, right? What are psychedelics? They're very potent 5-HT2A agonists. Psilocybin, ayahuasca, all these drugs that people, all these mushrooms, magic mushrooms. The problem is that sometimes the 5-HT2A receptor can lead to psychosis. So again, there's always risk benefits with the medication. Now, going to SNRIs. They're very similar to SSRIs, right? They do hit norepinephrine. I'll give you extra information, but this is just for your information because it's going to it'll kind of explain to you why some SNRIs still have sexual side effects. Right?
We can't hear you, Professor Collado.
Can you hear me now? Can you hear me? Can you hear me? Can you guys hear me?
Yeah.
We can.
Okay. Sorry about that. So venlafaxine, another name for it is called Effexor, is an SNRI. Just so you know the ratio of serotonin reuptake pumps that it hits as opposed to norepinephrine reuptake pumps that it hits is actually 30-1. So for every 30 serotonin reuptake pumps that it hits, only hits one norepinephrine reuptake pump. I'm giving you that ratio is because that's why SNRI still have a lot of sexual side effects, right? Now, it's not until you go higher on the effexor, right? Probably 150 milligrams, which is actually a decent SNRI. So if you go to 150 milligrams, the ratio changes. It's about 1 to 10. So for every one norepinephrine pump that it hits 10 serotonin. So the ratio is still much higher. That's why they're still prone to sexual side effects, weight gain, apathy. And the
So
problem, yes, question? Yep.
SNRIs hit serotonin
And
transporters more.
more than norepinephrine. More than norepinephrine. That's why you
Um,
still see a lot of the SSRI side effects with SNRIs. All right? You don't have to memorize the ratio. I'm just telling you the ratio to give you an idea of why that's happening, right? So it makes sense to you.
Professor Colado,
Yes.
is there a chance when you say the enzyme names, if you could either just write it or say it slower? Because sometimes, like when you're talking, it's hard for me to take notes and your mic is going in and out a little bit.
Is my mic still going in and out now? Is it still going in and out? Or is it better
I
now?
think it's when you move.
Oh, it's when I move.
Maybe if it's the keywords are written on the screen. Thank you.
So venlafaxine is one. Desvenlafaxine, another SSRI. That's Prestige. The only thing you need to know about the difference between venlafaxine and desvenlafaxine is that desvenlafaxine is the active metabolite of venlafaxine. So venlafaxine needs to be converted to desvenlafaxine through CYP 2, D is a dog, 6. Now let me ask you a question. If someone genetically by 2D6 for metabolizer, would giving them venlafaxine work for their depression? Think about that for a second.
Sorry,
No,
your mic is still going in and
I
out.
don't. I think the answer is no.
The answer is no. Can you hear me now? Is my mic still going in and out?
Yeah, it's like intermittent.
Is everyone experiencing that, or is it just you? Is it going?
It might be too
I
if
am too.
I am too.
Can we ask everybody to mute themselves? Because I think there's some feedback from some people coming through. That's the problem.
Yeah, if you guys can mute, please, and just unmute when you talk, and let me know if it's better. Give me a thumbs up if this is better, because everyone's muted. Is it better? Better. Okay. Perfect. Okay. Venlafaxine and desvenlafaxine, the significance of that, and I'm going to test you on this, and I'm going to say this because it's part of pharmacokinetic. If someone is genetically a 2D6 poor metabolizer, which means that they do not have enough 2D6 genetically, if you give them venlafaxine, it is not going to work for depression because venlafaxine needs to be converted by 2D6, an active 2D6, in order to turn into desvenlafaxine, which is an active metabolite. So the only time I would actually do a prior auth to switch someone and tell the insurance we have to give this guy Prestige is I did genetic testing and it shows here that they are a 2D6 poor inhibitor and I need to give them desvenlafaxine. Here are the results, right? They cannot metabolize venlafaxine to desvenlafaxine, all right? And that is through 2D6. Okay, makes sense?
Can I ask you something?
Yes.
Let's say, like you said, they genetic test for some enzyme and they're a poor metabolizer. Would you switch to a different medication or would you ever, if you ever went higher on the dose, like how does it work?
It depends on the medication. When it comes to the desvenlafaxine and venlafaxine, then yes, I would use that. But when it comes to other meds, I don't necessarily use genetic testing to guide my treatment because that's only pharmacokinetic. That's not telling me pharmacodynamic, right? So all I do is I make adjustments. If someone is a poor metabolizer, I just cut the dose in half, right? Or a quarter, depending if they're a rapid or very, whatever it is they meet on the scale. If they are a rapid metabolizer, it might be a little bit harder because if the medicine is expensive, they're gonna have to pay more to get above FDA indication, right? So that's a little bit harder. But if the medication works for them, then I could argue, hey, if you want to pay or I can convince your insurance to give me a higher dose, then we can give you a higher dose, right? Does that make sense? Okay. There is another SNRI that I use a lot myself because it has a lot of effects when it comes to chronic pain. For whatever reason, depression with chronic pain, if you don't treat both, there's poor outcomes, right? So duloxetine, I'm gonna draw here,
Symbol.
Cymbalta, duloxetine, right? Cymbalta.
Will you be on the exam? Will we be?
I'm gonna
Should
give
we
you
know?
the generic and the brand name together, all right? I'm gonna give both.
Oh, great, thank you.
If you remember dull, like dulling pain, DUL, that's how you remember. Now, the reason why duloxetine has a better pain profile, I wouldn't give someone Effexor for pain, is because the ratio of norepinephrine to serotonin is 10 to 1, and it wouldn't make sense to give someone a high dose of Effexor just for pain. You can give someone a decent dose of duloxetine that can help with pain. Because on the dorsal horn of the of the spinal cord, norepinephrine has inhibitory factors when it comes to the pain response. So just know that when you increase norepinephrine, norepinephrine is going to dull down that pain response and people are going to have relief. All right. They're probably going to be in other meds adjunctively also, but if you're going to give them a med for depression, why not give them something that also can help a little bit more with their pain? All right. So I would probably use duloxetine for those patients. All right.
Professor,
Yes.
real quick, Professor. So I know atomoxetine also has like that inverse ratio where it's a much more potent norepinephrine reuptake inhibitor than it is serotonin. So how come we don't use that for pain? Is it just because it doesn't hit
It
that
could
part of the
be,
spinal
but
cord?
I mean, there's no evidence. It's never been studied, so I would be talking off label, and I wouldn't recommend that. Only because, God forbid, something happens and the patient has a bad response to it, then you don't have any evidence at all, right? There's something I call Alway. I'm gonna write it here. Alway. It stands for off
Oh,
label
with, with evidence.
with evidence. Very good. And I use that a lot, especially in child psychiatry, right? Because no parents are going to approve their kids to go on these clinical trials. So a lot of times it takes a while to get enough of a power, right? Enough patients to test these medications. Believe it or not, we had no SSRIs until maybe last year that were FDA approved for general anxiety disorder. This is just for your information. It was Lexapro. How many years did it take them to finally get enough evidence to FDA approve Lexapro? Lexapro's been out since the 90s, right? 30 years. We were using it for GAD in kids off label, again, always off label with evidence, right? So if anyone ever tries to sue you, you're in court and they say, why are you using a med that's not FDA approved? You should be able to go through studies and find, hey, right, there's evidence that shows it's beneficial. And what am I going to do? There's no FDA approved medications for that. I'm talking about child psychiatry now. Some parts of psychiatry too, but you have to understand. That's why I'm teaching you guys the mechanisms because you can make scientific rationales for your treatment and they're going to make sense, right? You're not just going to hypothetically give someone a medication because you feel like giving it to them that day, right? There's going to be a reason for it, a scientific reason. Yes.
I'm sorry, at risk of the whole class hating me, I just got to ask a slight question. Like, is the FDA dogma? Like, if it's FDA approved, you're like, all right, FDA approval, I can do it. Like, or is there some FDA drugs that you don't really trust for what they were approved for?
For the most part, the FDA has a lot of politics involved in approving a lot of medications. So that's not my first, I use evidence more than I use FDA indication. That's just the way I practice.
Where do you find your evidence? Like, what do you have a preference?
I'm a maniac. I read all the journals. That's all I can say. I do this for a living, so I want to make sure that I'm up to date. And I teach. Obviously, teaching, students will ask me questions, so I want to make sure I give you guys the best evidence, right? So I read a lot of journals. I'm also a consultant for numerous pharmaceutical companies, if you don't know already. So this is my job, and I take it very seriously. So I just read about all this stuff, all right?
Is there a certain site that you go to
I
for
don't know.
them?
I get JAMA site. There's so many, APNA. There's so many journals. You can do that once you graduate. As of right now, just focus on what I'm teaching you, and you can always kind of, build up. All right, SNRIs. Know that they do hit norepinephrine reuptake pumps, right? But the ratio is still going to be higher for serotonin. There are going to be two classes of SNRIs that are actually equal or more, but you don't really see them a lot, right? The ratio is actually 2 to 1 and 1 to 1 for serotonin norepinephrine, but you don't need to know that because we use them more for pain management anyway. Levomilnacipran and milnacipran are the names. Levomilnacipran and milnacipran. But I'm not going to ask you about that. But that's just for your information. The ratio is actually 2 norepinephrine to 1 serotonin and 1 to 1 for the other. Levomilnacipran is only approved in Europe, it's not approved in the US, right? But you might see milnacipran. You might. I've only seen it a few times in my whole career, right? Okay. DNRI, Wellbutrin. I use a lot of Wellbutrin. DXL specifically, all right? The reason why I like Wellbutrin is because a lot of the common side effects that patients complain about when they're depressed is inertia, right? They have low energy, you have low motivation, and they have low mood, obviously, all right? And no one wants to gain weight and no one wants to have sexual side effects. So it's one of those meds that, yes, it can give you antidepressant properties, right? And not give you the weight gain and not give you the sexual side effects. But it does come at an expense. It is a little bit activating. So if someone has comorbid anxiety, Wellbutrin might not be the best first option, right? It's very stimulating. If someone has hypertension, Wellbutrin might not be the first best option. If someone has a history of psychosis, Wellbutrin might not be the best option. If someone has a history of substance abuse, Wellbutrin might not be the best option because they might crush it and they might sniff it, right? So those are my caveats with Wellbutrin, right? Wellbutrin also is a potent 2D6 inhibitor. So if you give it with other meds that are 2D6 substrate, just be aware that Wellbutrin could increase those levels as well, all right? Similar to Prozac. It's a very potent 2D6 inhibitor. Right. Wellbutrin can also be used for smoking cessation, right? It also been used off-label for anorgasmia. Some people who have like sexual disorders, some just has anorgasmia. Wellbutrin could be used for that as well. Smoking cessation. Another thing you should know about Wellbutrin that it lowers the
seizure threshold.
right? So if someone's like in college and they're binge drinking, you know, I've had college students have seizures with Wellbutrin. Just be aware of that, all right? So I tell them, now, let's be realistic, all right? I want to give someone Wellbutrin because, you know, I don't want them to have sexual side effects or a young adult to go into college. I'm not going to stop it because they drink alcohol socially, right? But I give them two answers. I give them the Richard as a healthcare professional, and I give them the answer of someone who understands or empathizes with them, all right? Most of the time, you take Wellbutrin in the morning, all right? It's going to peak plasma concentrations together with increased alcohol will have higher risk. There's never zero risk, but I tell them, if you're going to take Wellbutrin in the morning, take it in the morning, but don't have a mimosa at like 10 o'clock. Don't do brunch, right? Your risk is going to be much higher. But if you're going to drink with friends at night, maybe 1 or 2 drinks, you should be okay, right? But just be careful because, you know, the risk is always going to be there. So Wellbutrin can lower the seizure threshold. If there are other meds that lower the seizure threshold, what about if the patient is on topiramate for migraines or on lamotrigine for migraines? That has a protective effect. So maybe at that point, I might be more comfortable giving them Wellbutrin because they already have anti-epileptic medication on board. See what I'm saying? So you have to factor all these things when you're giving medication to your patient and have that conversation with them. All right? Questions. Wellbutrin is a good first-line medication. We pushed it up. It used to be like second line. But if there's no history of head injury, another risk of seizure is what? I hate the stereotype, but young female, skinny, thin, is on Instagram a lot. What is the risk factor? Anorexia nervosa, right? Big purging, electrolyte imbalance. So if someone has electrolyte imbalance and they're purging, they're not eating, lower seizure threshold. Also, I've seen that. Seizure risk of Wellbutrin as well. And also SSRIs, actually. SSRIs can also cause what? It lowers what are the major cations in our body?
Hyponatremia risk.
Hyponatremia, sodium, right? So SSRIs can lower sodium in patients. So that's another thing that you guys should be aware of as well. I'm going to pause for like a minute because I talked a lot and I want to make sure that you guys didn't miss anything. So we'll just pause for a second. So the 3 inhibitors on this chart that I wrote down, and if you don't know them, it's on my lectures, it's going to cause big fucking problems, all right? Bupropion, fluoxetine, and paroxetine. So if you don't know that, it's going to cause big fucking problems in your exam and when you're practicing, all right? Prozac, probably the most important one, gets a long half-life. It's hard to catch that, right? It stays in the system for a long time. Bupropion, half-life is, it's not that long, maybe a week. A week a day, so you can wash out fairly quickly, right? But paroxetine short half-life, so that one washes out pretty quickly too. But the Prozac could be a problem, so just be aware of that. SNRIs and DNRIs, since they're increasing norepinephrine, they can increase blood pressure. So if someone has hypertension, doesn't mean you can't prescribe them. But if their hypertension is under control, then you could prescribe them. All right. SNRIs, another caveat of SNRIs, and going back to them, is that they can also cause something called spontaneous antidepressant liver injury. So you probably should check liver enzymes at least once a month, once a year. I'm sorry, once a year. All right, because it's spontaneous, can happen anytime. So just to protect yourself from any liability, just have a liver enzyme checked. All right, or have their primary care checked if you want to. All right, if there's any flank pain, anything that's send them right away to get checked out for that. That's with SNRI specifically.
Would you get a baseline?
Yes, always a good idea to get a baseline. Very good. Yeah. I'm not going to focus on labs now because we're going to talk about that in 517. Well, they're going to talk about in 517. I'm not teaching 517, but you're going to focus on all that stuff. All right. But right now, I just want to make sure that you guys understand the medications. Someone who's on SNRI, check their blood pressure, check their liver enzymes at least once a year. DNRI, assess for alcohol use. Assess for any risk factors, electrolyte imbalances that could lower the seizure threshold. Contact sports. If someone plays football, does MMA, right? Just tell them, just be careful because Wellbutrin can lower your seizure threshold. It's going to be a higher risk of seizure also. These are things you just document, right? A patient, should be aware of that stuff. Questions? No.
Why are SSRIs so popular when we see they have quite a few side effects?
Because, well, a few things. Number one, right, they were the first to the market of the safest medications. Before the SSRIs, our options were monoamine oxidase inhibitors and tricyclic antidepressants, right? So the drug companies created a medication that could be prescribed in which if you took a lot of it, the overdose risk was very low, right? I've had patients take their whole bottle of Prozac and they're still alive. Some might develop serotonin syndrome, right? But it doesn't kill them like taking a week's worth of a tricyclic antidepressant, right? You take a TCA, you get widened QRS interval, unless you get them to the ER and give them sodium bicarbonate, they're probably going to die of a heart attack, right? The LD50 is the way you measure the amount of medications that will kill somebody. The LD50 is very low, right? So you don't have to you could take like a week's worth, but tricyclic. Like if someone was stable, let's say someone wanted to go on a tricyclic and they have a suicide risk, and they've tried every medication and they don't want to do intervention with me, I would prescribe tricyclic, but I'd probably give them like three days worth at a time until at least I know they're doing better and have a family member there to give it to them. It's not all, you have to partner with patients and family members. It's not off the table, but you have to make sure that you don't give them enough that they can overdose and kill themselves. All right?
Yeah.
Okay. Questions? No.
Professor, can you repeat the particular medications that are the inhibitors of 2D6 one more time for me?
Yes. Bupropion,
Yep.
fluoxetine, paroxetine. Right? If you remember the line, big fucking problems. Bupropion, fluoxetine, paroxetine, and I'll give you another one. High dose duloxetine. Could also be a moderate inhibitor. But I'm not going to test that because, you don't really see that a lot anyway. But that's just for your clinical information. Big fucking problems, duloxetine is another one that could be an inhibitor.
Thank you.
Right. I'm giving you guys extra, but, it's good for you guys getting your money's worth. All right? Questions? But the ones that I'm emphasizing are the ones I really want you to know, like the drug-drug interactions, the precautions when you're prescribing Wellbutrin, right? Precautions when you're prescribing SNRIs. SSRIs don't really have too many precautions, right? That's why people prescribe them so easily, right? One of my other jobs is I'm a site consultant for a collaborative care model, which I actually collaborate with a lot of primary care doctors. So I'm constantly lecturing about SSRIs and how they should use them, like constantly, right? And how to add stuff. But again, they're using it so frequently. My beef with them, which we're going to talk about next week, is that they're not doing a good, thorough screening for bipolar depression, and they're cycling patients because they're giving SSRIs so easily. That's the problem I have with them. But we'll talk about that next week when we talk about bipolar. All right.
Real quick, Professor. So your common go-to for the typical depression that you'll see is SSRI. So I take it that a lot of people are on obviously like adjuvant therapies. What's the next class that you're usually attacking on top? Like in more cases than
Yeah, we'll talk about adjunct. We'll just do the classes first. But that's hold your point. There's another student that asked about you too. Yeah. So based on the Harvard guidelines, if you were a trained psychiatrist in Harvard, what they use usually is called SEP. Sertraline, escitalopram, and ibupropion. Those are the first two they use first line. right? Based on Dr. Osser from Harvard. That's the one that he teaches residents to treat patients. And I myself tend to follow that anyway. If someone comes to me first episode, they've never been on any meds before, no drug interactions, they're not on any supplements, I'll really offer them. You want to try escitalopram, sertraline, bupropion. I'll go through the risks and benefits of all three, and then I'll let them decide which one they're comfortable with, right? If someone said, Lexapro sounds good because my mother was taking Lexapro, it did well with her. So I'd probably prescribe them the same medication, right? Because if a family member, first generation degree relative, responds to a certain treatment, the likelihood of that patient responding to that also will probably be good, right? The opposite as well happens. If someone says, well, my mom did very, very badly on sertraline, she hated it, I wouldn't offer her sertraline, right? Because there's a likelihood that he's probably gonna, or she's gonna do bad on it. And plus there's that negative connotation, right? It's like a bias. If you think someone did bad on something, you're only going into it expecting something bad because you've seen someone do bad with it. So I wouldn't even risk it. All right, that's just a clinical pro. Questions? All right.
Can you just go over again the pros and cons of the medications that you just listed? You just listed three, and you said, oh, for a patient, you'd go over the pros and cons.
Okay, so yeah, so Maria, I'm talking to a patient. How are you doing? It seems like you have depression. I'm gonna offer you three meds. So we have an option. We have sertraline, we have escitalopram, or we have Wellbutrin, right? The benefits of sertraline are that, besides fluoxetine, it has like the second least amount weight gain, right? Compared to that. So weight gain's an issue. Sertraline might be an option for you, all right? And if you're a little bit older and you might find yourself being on cardiac medication, it also has the best evidence, right? Another thing, sertraline also, we use that a lot in perinatal psychiatry, right? When I had postpartum patients, I would use sertraline because very little of it will cross when it comes to breastfeeding. So, a mother doesn't want to give the kid a lot of medication. So when it comes to the amount of medication that crosses the breast milk, sertraline tends to be the least. So there's a lot of studies. So even though you can use any SSRI technique besides Paxil, sertraline has the best evidence when it comes to least amount crossing. So I would offer sertraline. If you plan to get pregnant and you have depression, I would probably offer you sertraline. All right. Escitalopram, if, there was a family history of someone doing well on escitalopram, if I felt that you had no cardiac problems, if I felt that there might be drug-drug interactions later on, right, with other meds, not just cardiac meds, escitalopram is one of the cleanest, I would offer that to you. But just know, when they did a meta-analysis and compared all the SSRIs, I was shocked. I didn't expect escitalopram to be up there, but it was up there with Paxil. Paxil and escitalopram, patients gain a lot of weight, and I didn't know that. So that's something that I learned, maybe a year ago. So I tell patients that escitalopram Lexapro can cause a lot of weight gain. Wellbutrin, all right? Wellbutrin is great. No sexual side effects. Can actually even help with anorgasmia if you have that. If you want to stop smoking, right? If weight gain is an issue. But let's check your electrolytes. Do you drink alcohol at all? Do you have any head injuries? Do you purge or binge, right? Those are questions I would ask you. If there were no risk factors for seizures, then Wellbutrin might be a good option, right? Now, it's not one or the other. Going back to Joe, sometimes adjunctive therapy might be an option for you. I might give you a low dose of Lexapro with Wellbutrin, so they counteract each other. You get triple reuptake there. You get a dopamine norepinephrine reuptake inhibitor, and you get a serotonin reuptake inhibitor. All three in one. Triple reuptake inhibitor. Right? I give that to patients too. If you're okay with taking two meds, sometimes I recommend taking two because they counteract each other. You kind of get all of the symptoms. Remember, depression is not just a few symptoms, it's multiple symptoms. So you have to modulate multiple pathways of neurotransmitters to get the best response. So I'm not totally against. Oh, Tom. I'm gonna answer your questions. You email me. So Tom asked a good question. Would I choose Wellbutrin over antipsychotic? Evidence actually shows that, believe it or not, antipsychotics have a higher effect size when you add them to SSRIs. The problem is it worth the risk factor of EPS? Is it worth the risk factor of maybe tardive dyskinesia long term? That's a conversation you need to have with your patient, right? If you want the strongest effect size, Abilify might be the strongest effect size. Are you willing to risk weight gain? No, I'm a skinny guy. I just want to feel better. All right. Abilify might be an issue, a problem. Might be a good option for you, right? I just want to stop smoking cigarettes and I'm still depressed. All right. Well, Wellbutrin might be a better option for you, right? I'm having anorgasmia. Well, Wellbutrin might be a better option for you. All right. My cousin, my first degree cousin, I think he had schizophrenia. I'm not sure, but I'm still depressed. What do you recommend as an adjunct for me? If you told me that, I would be less likely to prescribe Wellbutrin for you because I don't want to innervate dopamine too much and make you psychotic. There are some case reports that show that. Why don't we choose Abilify or another atypical? Understand? See, but I'm giving logic here based on why I'm prescribing medication. Yes, Aaron.
I don't know why I understood Lexapro. I thought it was a weight neutral medication. I'm surprised to hear that.
Yeah, I was shocked myself too. There was a recent meta-analysis like a year ago when they compared them. Yeah.
Was it once thought that it was like,
I would see patients put a lot of weight with Lexapro as well, especially adolescents.
huh? All right.
I mean, everyone in general, I mean, there's paradox. I've seen people on Paxil not gain any weight, not have sexual side effects too. But in general, you want to make statistical based decisions, right? There's a statistical significance that there's a higher risk of this. What is your threshold for weight gain? Some people are more riskier than others. They just want to feel better, right? I can't sleep. I don't care about weight gain. I just want to feel better. I've tried all the other SSRIs. I think my mom did well on Paxil. All right, I might prescribe Paxil for you then, right? But see, I'm weighing all the different factors that you have to understand. I know it's complex. You can get more complex than that, but this is just touching the iceberg. All right.
So if you had a patient that didn't want to gain weight, which one would you pick sertraline first? Like which one would you
If they
give?
want to gain weight, I would probably do Wellbutrin. If they didn't want to gain weight at all and there was no risk of seizures, Wellbutrin would be the top of the list there. Yeah. Right. The SSRIs, because they hit certain serotonin receptors, right? The 5-HTC specifically, the 5-HTC, it actually inhibits the release of ghrelin and leptin, right? Both of those hormones they need to make you feel satiated and make you feel, hungry. So it makes you feel more hungry. Ghrelin goes up, leptin goes down, you don't feel full and you're more hungry. So that makes people gain weight, right? They get the munchies. All right, let's move to TCAs, tricyclics. Told you there's a lot of stuff today, TCAs. I break them down to two different classes, right? You have the tertiary amines, and you have the secondary amines, all right? Tertiary amines are more serotonergic, right? I'll put cert there. The secondary amines are more net, norepinephrine, right? But also they hit both. They're gonna hit both, but the tertiary is more serotonergic. What is a tricyclic? Pop quiz that we use a lot for OCD. That's very serotonergic.
It's not nortriptyline.
Imipramine?
Clomipramine, right? Clomipramine. And then we have these secondary amines like amitriptyline. Sorry, I always forget how to spell. Let me make sure I know how to spell it. Yeah. Google that. Sorry, it's so hard to spell these things. Oh, sorry. Amitriptyline is tertiary. Oops. My mistake. And the secondary are disipramine and nortriptyline. So nortriptyline and disipramine. Me personally, I use a lot of clomipramine for OCD, and I use nortriptyline for depression. The difference is the tertiary tends to have more side effects, more sedation, more weight gain. All right. The secondary amines and the more norepinephrine tend to have less side effects, right? But both still have that risk of, if they overdose, of causing widened QRS interval. All right. You'll see nortriptyline used a lot in pain management. Neurologists use it sometimes. All right. The significant thing that I want you guys to know, though, is that TCA's majority are metabolized by 2D6 substrate. I'll put substrate there. So what would happen if someone came to you and was like, yeah, I'm taking nortriptyline for pain. It was prescribed to me by my pain management doctor. And you were like, and they come to you and they say, no, I'm feeling depressed. And you put them on Prozac, or you put them on Wellbutrin, or you put them on Paxil. What's going to happen to the nortriptyline level? Or the clomipramine level? What's going to happen? It's going to go up, right? Doesn't mean you can't use it. Doesn't mean you can't use it. But you might have to tell them, cut your nortriptyline in half, right? Or tell your doctor that you're taking Prozac now or Wellbutrin, that's a potent inhibitor, and we're going to have to make adjustments to your other medications, all right? That's why it's a pain in the ass when you use these inhibitors, because you have to adjust the regimens with the other medications. But you could do it. The problem is when people don't know these interactions, and I've had patients come to me, I think I have ADD. I just can't focus anymore. I don't know what's going on. My primary care doctor put me on Prozac, and I just feel really confused. I'm tired all the time. Now let me see your regimen. Look at your med regimen. All right, they put you on Prozac. How long have you been on nortriptyline for? Years. I've been on it for years. I'm like, did your doctor counsel you that the nortriptyline levels will go up based on the Prozac? No, I didn't know that. Right? It happens. Of course, you can always rely on the EMR and it's going to bring up all these interactions. But the problem is you get so many interactions on the EMR that what is significant, right? It's going to give you all the risk of serotonin syndrome, right? All these other side effects. Which one is really significant? So that's why I'm trying to emphasize that you guys should still understand it and do not rely on an EMR, all right? The best EMR is you. The best EMR is you because sometimes they'll give issues, and I'll argue with pharmacists all the time, and it's not significant, right? They're going to go with EMR and it's not a significant side effect because the risk is low. And I'm like, come on now. Like lithium given to an SSRI, there's a risk of serotonin syndrome. But even in the STAR-D trials, lithium was one of the best augmenters when it came to treatment-resistant depression. We use lithium pretty regularly, right? So I mean, if you go by the EMR and you don't understand, you're gonna freak out and you're not gonna want to add any medication, right? So tricyclics, they're still very good medications. I still use them, probably second line, right? Especially if patients have already been on SSRIs, they've already been on SNRIs, they've already been on DNRIs. I will do tricyclics. I'll give them a trial tricyclics because they're very good meds as long as the prescriptions are not being written. Don't give them a 90-day supply of nortriptyline, right? Or clomipramine, right? That would not be smart. But give them, I don't know, a week. Come back, let's check back, right? What are the side effects? Dry mouth, constipation, right? It's anticholinergic, right? It also blocks sodium channels, so that's why it causes arrhythmias because it blocks the sodium channels. It blocks the sodium in the cardiac channels, so it can cause arrhythmias. So that's why they're more dangerous. But everything is dangerous if it's not prescribed appropriately, right? So I'm hoping you guys can prescribe stuff, you know, for these patients because the problem is patients are being put on SSRIs, SNRIs, DNRIs, and everyone's afraid to use these older meds like tricyclics and monoamine oxidase inhibitors, and patients aren't getting better, right? But you can still try them. They're cheap, number one, right? And if someone has bad insurance, they can afford it. And if it's monitored, it could be life-saving for patients, right? Questions with tricyclics. Just know, potent anticholinergic, potent antihistamine, block sodium channels, right? Serotonin reuptake, norepinephrine reuptake, both of them, secondary and tertiary. But the difference is tertiary is more cert, a little bit less net. Secondary is a little bit more net, a little bit cert. But secondary is usually better tolerated than tertiary, usually. Questions?
Are we, do you want us to know the doses and the half-lives for the test? No. Okay.
But I want
Thank
you
you.
guys to know the mechanisms of action, know the CYP enzymes, and the interactions with these medications. That's important. All right.
Great, thank
Can I
you.
ask a,
Great question. This is a great question. I asked this actually last semester. I might ask it again this semester. Patient comes to you on a tricyclic antidepressant, whichever one, doesn't really matter, right? Comes to you and says, I can't focus anymore, I'm tired all the time, right? And they're on SSRI. Which SSRI do you think they're on? And I'll give a hint, right? It's an SSRI with a long half-life. What do you think it is? Fluoxetine.
I-
Right? SSRI has a short half-life. What is it? Paroxetine. Right? Patient complains of weight gain and a lot of sexual side effects and withdrawal. They're on an SSRI. Which one is it? Sexual side effects, weight gain, withdrawal symptoms. So you should be looking.
Lexapro,
Paraxetine, Paxil.
Lexapro,
Yeah, Paxil.
citalopram.
No, that's not. No, Paxil. Number one, withdrawal symptoms, short half-life. Meds that have short half-lives tend to have more withdrawal symptoms, right? Short half-life, more withdrawal symptoms. Anticholinergic, dry mouth, constipation, blurred vision, whatever, not drooling, you know. Sexual side effects, right? Inhibits nitric oxide. All the SSRIs can cause sexual side effects. But Paxil particularly has that extra caveat too. It has more sexual side effects than all the other, SSRIs. Let me pause like 2 minutes because I did talk a lot there, so you guys can digest it. All right. So there's drug-drug interaction with potent 2D6 inhibitors and tricyclics. Know that. Monoamine oxidase inhibitors, MAOIs, right? You have let's see if I can spell tranylcypromine is one, phenolzine is another one, isocarboxazid is another. And another one is selegiline. The advantage of selegiline is that it's a patch. So patients don't have to take a PO med, and selegiline tends to have less dietary restrictions. What is dietary restrictions with monoamine oxidase inhibitors? What? 8 cheeses.
Tyramine?
Yes, it can cause tyramine overload, right? Too much tyramine can cause hypertensive crisis. So anything that can increase tyramine, specifically wine, aged cheeses, certain meats, cured meats, right? So be aware of that, right? Another thing that can cause that is cold medication. I had a patient take a cold medication while he was on tranylcypromine, 60 milligrams twice a day. And I was like, please, please do not take cold medication. He forgot that I told him that. He took cold medication. He felt like he was having a heart attack. He had ephedrine in it. What is ephedrine? Increased norepinephrine. He took that. The body couldn't break down the actual norepinephrine. He went to the ER. And yeah, I don't know what they did in the ER, but they stabilized him there and they sent him home that night. But yeah, they probably monitored him and brought his blood pressure down. But just be aware, cold medication, anything that increases serotonin. I see that also with pain meds, right? Some opioids can increase serotonin also. Some pain medications can also increase. So just be aware that there could be interactions. So monoamine oxidase, it can be prescribed, but just be aware of the interactions, right? Anything that increases any of the monoamines, serotonin, dopamine, or epinephrine, could drastically go up. So you just have to monitor them and make sure that they're aware of those interactions. All right. Tranylcypromine in general tends to be more activating. All right. So I tend to give that to the patients who have really bad anergic depression. Getting out of bed, they're moving slow, psychomotor retardation, right? Or bradykinesia is another term. I know we like to use a lot of terms in psychiatry. Bradykinesia, slow movement, right? It's like they're moving in quicksand. Psychomotor retardation is another way of saying that too. They're moving very slow. All right. They can't get out of bed. They're laying in bed. A lot of neurovegetative symptoms. They're not eating. They're not talking. Right. They almost look like a vegetable. Phenolzine tends to be a little bit more calming. So if someone has comorbid anxiety with depression, phenolzine might actually be a good option for them. Right. It actually has a GAT inhibitor, which is a GABA reuptake pump inhibitor. So it increases GABA, so it calms people down a little bit. Right. Isocarboxazid, I don't really see that prescribed anymore, so that's not really safe. So allegedly, I do see occasionally, because if you put the patch on, a lot of times, people could still eat a little bit of those things I talked about, but it's not going to interact with it. But if you go high enough with the dosing, it could still interact with it. So let the patient know. All right. Questions? So monoamine oxidase.
I read.
Yes.
Sorry. I read with I'm not good at pronouncing these. Selegiline, that it's a MAO
Selective.
A. But then it said at higher doses.
Yeah, it becomes A and B. See, that's what I'm saying. It becomes a different drug based on the dosing. Yeah.
What drug?
Selegiline patch. Yes.
So then you really can't, because then it said, oh, but the side effects aren't as strong. But then you're still at risk for hypertensive crisis, right? At high doses.
Of course. So the problem is that the selegiline patch is usually used for Parkinson's, right? If you want to use it for depression, you have to go a little bit higher, and sometimes the insurance won't pay for it because you have to go at a higher dose. It's a little bit more expensive. Remember, A is selective only for the treatment of Parkinson's, right? Dopamine. You have to inhibit B to affect the other neurotransmitters. So from a practical standpoint, so that's a challenging part, right? The meds you can prescribe, but if the insurance sucks or the patient can't afford it, you have to find ways to work with it. I'll give you an example. There was a med that came out before it was branded only called Vilazodone, right? That's one of the newer meds, Vibrant. Vibrant is, I'll put it here, Vilazodone, which is generic now. It's one of the newer class medications. It's an SSRI with a 5-HT1A PA partial agonist properties, right? It was a pain in the ass to get PA, prior authorization. The reps would come give me samples, but when I tried to get the PA, it was a pain in the ass. So what I did was I would prescribe them an SSRI, and we're going to talk about this in anxiety, but anyone know what a 5-HT1A partial agonist? What's a good example of it?
Buspar?
Buspar, very good. Busparo. So I made my own. I made my own cheap vilazodone. I gave them an SSRI and a 5-HT1A partial agonist. The downside is that the half-life is much shorter of vilazodone. You have to do it BID or 3 times a day dosing as opposed to vilazodone, which is once a day dosing. But they didn't have to pay $1,500 a month for it, right? Or they have a high copay for it with their insurance. They got it for like $10. You know what I mean? So you can kind of create your own, technically, you can combine a lot of these treatments and kind of make your own tricyclic or your own monoamine oxidase inhibitor sometimes. Like for instance, Stahl talks about this, and I've used this combination as well. What is California rocket fuel?
Effexor and mirtazapine.
Very good, right? So that is what? SNRI. SNRI, I'm sorry. And a NASA. A NASA is actually mirtazapine. Why is it called NASA? What does NA stand for?
Noradrenergic.
Antagonist. Very good. Norepinephrine antagonist. So norepinephrine antagonist. What does SS stand for? Specific serotonin antagonist. So SS stands for specific, I'll put 5-HT antagonist. So you know 5-HT serotonin, right? So mirtazapine is a very interesting medication, right? It's a norepinephrine antagonist, specifically an alpha-2 antagonist, which increases dopamine, norepinephrine, and serotonin in the frontal lobe. It's a specific serotonin antagonist at the, what? You guys tell me. 5-HTC. I'll put that 5-HTC, 5-HT1A, and 5-HT2A. Right? What does that even mean? All right. Alpha-2 antagonism. Alpha-2 is a heteroreceptor on a serotonin neuron. So when you antagonize so hetero just means that it's a serotonin neuron, but it also has norepinephrine receptors on it, even though it's a serotonin neuron, right? Even though it's a serotonin neuron doesn't mean it only has serotonin receptors on there. It has a norepinephrine receptor on there. So it's a heteroreceptor. So when you give a med that's a 5-HT2A antagonist, it's going to block the break of that serotonin neuron, and it's going to increase the release of that serotonin neuron. Does that make sense? Now, 5-HTC is in a GABA interneuron. So it's actually going to inhibit GABA from secreting GABA, which inhibits, right? So when you stop GABA from inhibiting, you're also going to get downstream increase of serotonin, norepinephrine, and dopamine. 5-HT1A, like I said, is a brake, right? You don't have to downregulate it with SSRIs. You just block it with mirtazapine, right? It's also a dopamine neuron. So if you block it, it's also a brake in dopamine neurons. It's going to increase dopamine. And it's also a 5-HT2A antagonist, which also increases dopamine in other parts of your brain. So you see how, like, if you know the receptors, you can kind of understand how the meds are working. It's complex, it's complicated, but take the time to really understand it. What I did as a student is I would draw out the meds and I would write down the receptors, and like a language, I would say, this is the receptor profile of this medication, therefore I'm going to expect this, this, and this, right? It takes a lot of work. You have to draw it out. But if you do it and you invest the time, it makes it so much easier, because then you'll know exactly how the patients are going to benefit from the medications. Does it make sense? Would you give, this is a good question, would it make sense to give, if someone was on California rocket fuel, right? They were on Effexor, and they were on mirtazapine, and they were on Buspar 3 times a day. There's irrelevant polypharmacy there. Where's the irrelevant polypharmacy? What would you stop? And you explain to me what's the relevancy there. What?
I'd probably stop the Buspar.
Very good. Why?
Well, I would think that they would, I don't know, I could be wrong, but this serotonin, too much serotonin.
They're both getting 5-HT1A receptors. There's no need for the Buspar.
Redundant.
So that's how you clean up the medication regimen, right? You cannot clean up medication regimen if you do not understand the mechanism of action of the psychiatric medications. You're not going to know. Like, I can look at a med regimen, and within 2 seconds, I can say there's an interaction there, an interaction there. You should stop that. You should increase that, right? You're not going to get to that right now because you guys are still learning, but that's the point you want to get to. because that's gonna, number one, give the confidence. The patient's gonna be like, oh my God, this guy knows what he's doing, right? He got me better, and other people miss this interaction, right? And number two, it's gonna reduce polypharmacy. Number one, you're gonna gain a lot of trust. The patients that had the longest rapport with me that have stayed, I've been practicing for 8 years now. I have patients with me that have been with me for 8 years. And if I practice for 20 years, I guarantee you they'll probably be with me for 20 years, right? And I treat whole families. Because these patients came to me from other providers. I'm not talking about other providers, but I was able to look at the meds they were on, and within 5 minutes, I said, this is the interaction. Let's adjust this and this. And they're like, oh my God, I feel so much better. I didn't add any medication. All I did was adjust the meds they were on already, and they're doing better, right? So you don't always have to add meds. You can just adjust what's already on, because sometimes it's not the medications they're on, it's the dosing of the meds and the interaction that's happening. But unless you understand these mechanisms, it will be impossible for you to figure this out, right? That's why I'm making this example, because even though it's hard, this will make psychiatry so much easier for you. Yes, Madison.
I imagine you're gonna say no because there's so many, but do you have a way or a trick that you memorize the specific enzyme names? Because like for me, I feel like it's so
It is
hard.
hard. I don't really have a trick. What I do, to be honest with you, I try to think about dirty things in my head, like big fucking problems, or if someone told me they had two dicks, 2D6, they're probably crazy, right? Because 2D6 metabolizes a lot of antipsychotic medications. Do you know what I'm getting there? Like, whatever gets you to remember these things, you use it. I know I'm being inappropriate, but these are ways for you to remember. These are ways I use it. So, I mean,
Okay.
these are the only tips I use, right? Link the meds to something you already know so that you can apply that knowledge so it's not new knowledge. You know what I mean? Like, how can I, like, when you look at a patient, if you're working in psych, try to see, well, these are the receptor binding profiles, and the patient is responding to these treatments. What is it in this medication that's probably causing that, right? You have to kind of visualize it. But, it's not easy. Psychopharm is not easy. Look, people think it's easy, it's algorithm based. It's really not. Like, there's a lot of people that practice out there algorithm based, and they're actually okay. But I'm not here to stabilize 70% of the population, right? I made a good reputation for myself by stabilizing the top 5%, the patients that couldn't get stabilized by psychiatrists, all other NPs, and they came to me and I stabilized them. I get a lot of, I feel rewarded. My dopamine pathways are flooded with that, right? That's what I live for. So the only way you're going to stabilize those patients are by learning psych the way I'm teaching you right now. Because you can easily go out there and just memorize algorithms, and you can say, well, let's start Prozac, that doesn't work, let's do Wellbutrin. And maybe 80% of the patients will do just fine. But what about the 10% or the 5%, right? We can refer them to me. Sure, I'll take them. But I would prefer you to stabilize them. Yes, Marie.
Um, would you mind just giving one example, like drawing out a med with the receptors of how you would write it down? I was thinking of doing flashcards, but so I was just curious how you would write it down if you weren't going to do a flashcard.
Yeah, I mean, let's do Prozac. Prozac, fluoxetine. All right. I'll probably put long half-life. The number doesn't matter. You can put a week. It's approximately a week. Long half-life. Just know that, right? Long half-life. Long half-life. 2D6, 3A4 inhibitor. SSRI. Well, I'm not, don't put SSRIs. We know that already. Sorry. It affects CERT. It affects NET a little bit, right? It also hits 5-HT 2C, right? Like that. You know what I mean? Just like, and you can add to it.
And then would you add like what 5-HT2C does? Like I just
Yeah, right. I mean, you could. Yeah, you could. That's why, like, the investment is understanding the receptors and understanding what they do so that you can break it down like this, right? It's like
okay,
learning.
because I read about
Yeah.
5-HT1A, and then the 2A affects like nausea, the side effects, and I think the HT3, but
I mean, yes, is a very potent anti-nausea. That's why Zofran is a 5-HT3 antagonist, right? So that's why if a med has 5-HT3 antagonism, it also has antidepressant properties because it's on a GABA interferon, and also affects the gut because it also helps with nausea. Yes, so that you are correct.
all right, great, thank you.
There's no way to avoid memorization. I'm trying to like I'm hoping that these lectures are knowledge based, right? I'm giving you wisdom because I can't just write the meds and say well, half-life and 2D. I can do a little bit, but if you know that already coming into these conversations, we can have very high level conversations. And I can say, let's talk about a case today, right? It was a patient that came to me and they had this and this. What do you think is happening? And we can troubleshoot it. I did this with one of my other classes that really like they were very sharp. I'm not saying you guys aren't sharp, but they did a lot of reading and they came in and they kind of knew this already because they were very prepared. So I even had extras. There were some lectures where I said, you're on a deserted island. You're allowed to make two medications. Give me what receptors they would do, what the half-life's going to be, how they're breaking down, and I want you to explain to the class and sell me this medication like you're a farmer. That's what the level they were at. And they were very smart. And we talked about a high level, right? What are the interactions? Why do you think this medication is good, right? And they created their own meds. How is it metabolized? Is it lipophilic? Like, what are the advantages of that, right? Or even easier question, which you might do. I mean, we reserved the last 2 weeks of this class as like filler, where I can talk about whatever it is you want to talk about. You're in a desert island. You can only pick two medications. It could be an antipsychotic, antidepressant. What would it be and why? Some patients like, I'll pick lithium and Abilify. Give me the reasons why. Right? So you have to look it up. But these are good exercises because in reality, you have to understand we're working with limited treatments here, right? Especially for depression. It might seem like we have a lot of different options, but we're really just modulating neurotransmitters, right? Of monoamines at this point, increasing dopamine, norepinephrine, and serotonin. We're really just modulating those. That's why there's a move now to really try to find other ways that increase synaptic plasticity, right? Like NMD antagonist, like IVK, like Spravato, like TMS. But you have to understand how these basic meds work first, where we can talk high level about these other treatments. All right, it's a lot, but keep reading. I can always clarify for you. But if I can do it, you can do it. I started where you guys were. I was just like you guys. So if I can do it, you guys can do it. All right. NASA is mirtazapine. There's another class called Aspari, Spara, and that would be trazodone. SP stands for serotonin partial agonist of the 5-HT1A partial agonist, right? And RI, what do you think stands for? Reuptake inhibitor. So it's actually an SSRI. The problem is if you don't prescribe trazodone above 100 milligrams or 150, it's not an SSRI. It's only going to work as an antihistamine sleep medication, right? It also has some alpha blockade also, alpha 1 block. Forgot about that one. That's significant because if people have nightmares, they're having flashbacks from PTSD. I use trazodone at night because the alpha blockade helps with the fight or flight response and it calms them down a little bit.
Is it ever used purely as a antidepressant anymore?
I use it purely as antidepressant. I do, but not many other providers do because they're afraid of priapism. But you also have a medication that does very low sexual side effects as well. The reason why trazodone is not used a lot is because people are afraid of orthostasis, right? People change positions and they have orthostatic hypotension and they hit their head, right? Or two, the risk of priapism. But if you want a med and you assess the patient and you're checking for priapism, you're checking, for orthostasis or hydrating, it's a good option. I still use it. Yeah. There's still value in using the old medications, right? Using an antidepressant dose of trazodone, an antidepressant dose of mirtazapine, because they're not just serotonin reuptake inhibitors, they're also hitting other. You see the theme that I'm giving here, right? The meds that are more broad in general sometimes are not the best meds because they cause more side effects. The meds that have antagonism with specific serotonin receptors tend to work a little bit better. Does it make sense? The theme is what I'm giving you here. And you can mix and match. You can give someone an SSRI and not go super high if they don't have a lot of sexual side effects and add trazodone at night as an adjunct. That's actually evidence-based. If someone says, I have depression, I have PTSD, I have nightmares, right? Trazodone might be a good option, all right? Another thing, which is a little bit extra, but I'm gonna give you guys clinical pearls. SSRIs mess with sleep architecture, right? If patients got to put on SSRIs, it actually messes with their deep sleep. They're not gonna have good restful sleep. Deep sleep is where you really feel rested. So they're gonna sleep, but they're gonna wake up, they're gonna feel unrested, or they might even have insomnia that they didn't have before they were on SSRI. Because the problem is during the sleep cycle, your serotonin your serotonin in your brain is going to have to be either high and low. And during deep sleep, your serotonin is actually supposed to drop a little bit. But if someone's an SSRI and you're artificially increasing the serotonin, right? Especially with Prozac, long half-life, during that part of sleep, that phase of sleep where the serotonin is supposed to drop and hit deep sleep, it's not. It's going to stay artificially high. So patients will either have vivid dreams, they might have nightmares, they might wake up in the middle of the night, they might not feel rested, right? Giving someone a 5-HT2A antagonist like trazodone counteracts that, and also alpha blockade also helps with the hyperarousal, right? So that's a clinical tip I can give you. If someone has sleep issues with an SSRI, trazodone at bedtime helps with that, and I use that a lot. It also adjuncts mood. If someone has low appetite and has issues with insomnia, mirtazapine, because mirtazapine also helps, because also I didn't write it there, sorry, 5-HT3 antagonism, right? It also helps with nausea. That helps people eat a little bit. If someone's skinny or someone has chemotherapy and they feel depressed, we sometimes use mirtazapine for those patients. So in a nutshell, SSRIs, I use first line because they're very easy to prescribe, right? There's no blood monitoring usually. Assess for hyponatremia, right? Watch for fluoxetine and paroxetine because they are very potent 2D6 inhibitors. Be careful with fluoxetine because it's very long half-life, right? Be careful with Paxil because it has caused a lot of sexual side effects, very anticholinergic, antihistamine. Waking can also make patients a little upset. And it's also very potent 2D6 inhibitor, right? SNRIs, they increase both serotonin and norepinephrine, but be aware of blood pressure, right? Make sure you check blood pressure. Yearly check for liver enzyme elevation because it can cause spontaneous liver injury, all right? SNRIs could be beneficial for patients with comorbid pain, right? Specifically, duloxetine, all right? Because the ratio of serotonin to norepinephrine is about 10-1. 10 serotonin for 1 norepinephrine. Norepinephrine inhibits the pain pathway at the dorsal root of the spinal cord, all right? If you see someone on milnacipran or illegal milnacipran, if you're in Europe, just know it's probably being prescribed for pain, but it does have some antidepressant properties. So if someone came to you on milnacipran for pain, but they were having depressive symptoms, I probably would just increase the dose of the milnacipran, all right? And so if someone came to me on nortriptyline and they were on nortriptyline for pain and they came to me for depression, I probably will just increase the nortriptyline. Now notice the strategies that I'm using. I'm not adding anything more. I'm just trying to maximize what med is already there. It also has antidepressant properties, all right? For nortriptyline, for whatever reason, the anti-pain properties are much lower doses. So you might see nortriptyline 50 or 100 milligrams, right? But for antidepressant, you might have to go a little bit higher. So push up the dose a little bit. Don't be afraid, all right? As long as the patient is not having any symptoms of anticholinergic, antihistamine, sedation, or you look at the EKG and the QRS interval is starting to get widened, all right? There's some kind of abnormalities there in the EKGs, all right? Wellbutrin, 2D6 inhibitor. Be aware of patients who are on meds that are 2D6 substrates, all right? But very good for patients who are afraid of weight gain, afraid of sexual side effects. Also want to stop smoking. Wellbutrin is a good option for that, all right? Or patients say, you know what, I'm depressed, but I think I have ADHD. My cognition is really bad. If the cognition is only there during the depressive episode, it's fair to say maybe it's a depression that's causing the what do you mean? Have you ever taken a test after a breakup? That's depression, right? If you guys don't know what depression is, take an exam after a breakup or after losing your job. That feeling of not being able to focus on the exam because you have things happening and you feel sad and you feel down, that's what depression is, right? That's cognitive issues caused by depression. Wellbutrin, seizure risk, alcohol use, any history of eating disorder, right? Specifically purging or restricting behaviors. Check for electrolyte imbalances. Check for any head traumas, right? Monoamine oxidase inhibitors, all right? Be aware of the dietary restrictions, right? Aged cheeses, wine, cured beefs, all right? Cough medication, anything that increases SSRIs, anything that increases the neurotransmitters could potentially have a reaction with monoamine oxidase inhibitors, all right? SPARIs, serotonin partial agonists, reuptake inhibitors. Trazodone, right? Good for sleep, good for stabilizing someone who has issues with sleep when they start an SSRI, right? Also good as monotherapy for patients who are afraid of sexual side effects, right? But be aware of orthostasis. There are a lot of other meds that are alpha blockers. We'll talk about that when we talk about schizophrenia, antipsychotics, risperidone. I had a patient on risperidone, put him on trazodone, he took a hot shower, and he passed out in the shower. Because risperidone is a potent alpha blocker, trazodone is an alpha blocker, and he took a hot shower, passed out. Right? NASA, norepinephrine antagonist at the norepinephrine 2 receptor, alpha 2 antagonist on a serotonin neuron, which is a hetero receptor. Specific serotonin antagonist, 5-HT2A, 5-HT1A partial ag. Yes, Joseph.
I'm just real quick. Can you backtrack to so the patient was on 2 alpha blockers, took a hot shower and passed out because he was getting adrenaline from the hot shower, but the receptors
It wasn't the
were
adrenaline,
blocked.
it was the fact that heat can cause your vessels to dilate.
Right.
Yeah.
Okay, cool. Okay. Thank you.
I remember, if you guys don't remember, I teach neuroanatomy and physiology too, so I'm a geek. But when you change positions, right, your locus coeruleus has a reaction, right? It's going to secrete norepinephrine to tell your body, I have to increase my blood pressure because blood has to rush to my brain when I change position, right? When you impede that by giving them an alpha blocker or a beta blocker, that reaction is not going to happen. So when they change position, remember, is that a pharmacodynamic or pharmacokinetic interaction?
Dynamic.
Dynamic, very good at the receptor side, right? So they're not going to have that reaction. Their blood pressure is not going to accommodate based on the change of position, right? When you go erect, they're going to pass out, right? When you stand up, blood pressure is going to go down because gravity is going to push down. What counteracts gravity? Your body's secreting norepinephrine to tell your body to pump a little bit harder, right? I'm just explaining this because, you have to understand the mechanisms of stuff, or else you're not going to be able to help anybody. Tricyclic antidepressants, right? They work on norepinephrine, serotonin transport pumps, right? The tertiary, the one with 3, acts on more serotonin, therefore clomipramine I use for OCD. When we talk about OCD, you're going to learn that one of the main treatments is saturating the serotonin reuptake pumps, right? Oversaturating sometimes. Secondary amines, better side effect profile, hit norepinephrine a little bit more, all right? NMD antagonist, are you guys overwhelmed? Because I don't want to overwhelm you. You want to hold this for next week and we'll just review stuff and answer questions, or do you want me to go into NMD antagonist? It's up to you.
Could you go into it?
Good, sure. NMD antagonist, we have a new one now. Auvelity. A is the brand name because it's not generic yet. Auvelity. You're gonna see commercials a lot. I prescribe it a lot, and I think it's a great medication. It's actually a very interesting med. It's 2 components. There's dextro, Thorphan, right? Which is cough medication. You guys didn't know that, right?
Wellbutrin.
And bupropion or Wellbutrin, right? There's a pharmacokinetic and a pharmacodynamic interaction there. All right. Dextromethorphan, if you take it normally, that's why a lot of college students take it to abuse it, right? Is if you take it, it gets converted to a substrate by 2D6 called dextrorphan, right? Dextrorphan, which is abused. It's actually a very potent NMDA antagonist like PCP. It makes you psychotic and it gives you euphoria. Now, the drug companies, they figured that if they give Wellbutrin, which is a 2D6 inhibitor, they're stopping that conversion of dextromethorphan to dextrorphan. And dextromethorphan by itself has properties that help with depression, right? So it's a bupropion working pharmacokinetically to stop that metabolite from forming, right? So it stays as an antidepressant. And bupropion itself, as you know, is a dopamine norepinephrine reuptake inhibitor. It's actually very clever. So you're getting buy 1, get 10 free, all right? The problem with that sometimes is patients, you're innervating the sympathetic nervous system, right? So high blood pressure, increased anxiety, right? Maybe, there could be some case reports of psychosis or mania. So just be aware of that. But if someone has allergic depression, they can't get out of bed, they don't want to take an SSRI because they gave them sexual side effects in the past, right? Now, I'm going to tell you something. I don't really talk bad about other providers. I'm not going to give his name. I had a patient that came to me recently, and they had treatment-resistant depression, and they said, I just fired my last provider. I'm not going to say if it's a psychiatrist or NP. Because the provider had put them on Wellbutrin 450, and they had a seizure. They were in the ICU for a bit. They had a seizure, really bad. They were put on their seizure hit their head. It was a really bad thing. The parents came and they're on anti-seizure meds now. I think they're on God, what are they on? Doesn't really matter. But the problem is the prescriber was like, "Oh, I'm really sorry that happened." She came back to him because she's been with this doctor for a long time. And they were like, "There's a new med you haven't tried yet. Why don't you try Auvelity?" She's a social worker, so she's smart enough to look up the medication. She was like, "Are you trying to kill me? Jake, you almost killed me with the bupropion. There's bupropion and the Auvelity. So please do not make that that mistake. Reach when you find a new med that comes out, find out what's inside the medication, please. All right. Like the med for smoking. What's the it's bupropion SR. It's called Zyban, Zyban. You know how many patients I've seen on Zyban for smoke cessation, and they're on Wellbutrin by somebody else, and they're not aware that Zyban is Wellbutrin, right, with a different name. So please do yourself a favor and find out if a med is not familiar to you, find out what the generic name is and what the active components are. Like Tylenol, right? There's Tylenol in a lot of medications. You want to make sure what the component is so someone doesn't have Tylenol toxicity. Even though 4 grams is a pretty high dose, but if someone's taking Tylenol around the clock and they're taking other meds with Tylenol, like cold meds, it can put them over the top very quickly. So just be aware. Auvelity has bupropion in it. So you would not prescribe it to a patient who has seizure risk, right? Same risk factors. Eating disorder, yes, question. Aaron.
Now, this is still on brand, right? Because this just came out recently.
It's only branded. It's only branded. There's no generic.
So it's probably pretty expensive.
It is, but a lot of farm companies are giving coupons or samples. So I have a lot of samples in my office.
What
I
stops?
using it for patients as a maintenance dose for Spravato or maintenance dose for ibuprofen.
So can you just prescribe someone Wellbutrin and do over-the-counter cough suppressant?
Yeah, because what happens if they miss the dose of Wellbutrin?
Yeah,
It's
I'm
risky.
just thinking
Yeah.
money-wise.
Yeah, and it's hard to find that ratio sometimes. Because remember, these drug companies really fun. Like Symbi, what is Symbiex? I know I'm jumping about. I'm giving you guys different. Symbiex is a olanzapine fluoxetine combination, right? But to find that combination exact, the farm companies made the combination like a I don't know, it's like 12.5 or whatever. It's like a weird combination where you can't unless the patient cuts the meds. It's very hard to find that combination. And the evidence, right, based on the trials, is only based that combination. Now, I'm not saying patient won't respond to it. But what happens if a patient has a bad reaction and they have a good lawyer and they say Joseph didn't want to prescribe me Symbiox? I don't know why. I was willing to take it. He said it's cheaper if I just do a olanzapine fluoxetine combination. What was the ratio? It's very different. Patient had decided. What are you going to say in court? There's no all way there. There's no off-label with evidence because there's no evidence to show that this ratio helps with bipolar depression, right? Or treatment-resistant depression, the two indications for Symbiox. See what I'm saying? Like it's a big headache, and you don't want to put yourself in that situation. All right, it's complicated, but if you want to be a good prescriber, a great prescriber, you have to know this stuff. Yes, Aaron.
No, it's just wild that these medications are inexpensive
Yeah.
together.
Now, look, I would be lying if I said I didn't make my own combinations for because I treat college students too that are broke and they don't have good insurance. But I try my best to work with them and give. But if they have insurance, it's not worth the risk, right? Or giving them if they have insurance, might as well just try to get it approved. Yes, Marie.
So for the ability, it's for depression, but if you were to have anxiety, don't use it. And if you were to
There's
have
no
history of
indication for anxiety. It's only for treatment of depression, not even treatment-resistant depression. I want to be very clear. It's only for MDD, not treatment
okay.
and not anxiety. There's no indication. Who knows? Maybe 5 years from now, there's going to be some retrospective studies in which they say, "Hey, let's do some clinics that have taken Auvelity, they have comorbid GAD, right?" And they're going to do those scales and check. Maybe I don't know. And
Are we talking about Spyax right now? Which med are we talking about right now?
Auvelity, AUV, the NMDA antagonist medication.
Can you say it one more time?
I'm sorry, Auvelity, Auvelity, Auvelity. And the other NMDA antagonist is actually lamotrigine, Lamictal, all right, which I use a lot for. Again, this is all the way off-label with evidence, but it's also could be a good option for patients who are not responsive to SSRIs, who've tried every mechanism. So what happens is that, let me see if I can draw this for you guys. So a neuron here has different receptors for glutamate, right? There's NMDA. There's AMPA. I'll just do NMDA and AMPA. There's another one, but you guys don't need to know that one. I don't want to confuse you. If you block NMDA, right, you're forcing glutamate to bind to AMPA. If glutamate binds to AMPA, it's going to cause a reaction that causes the release of brain-derived neurotrophic factors or other growth factors, right? So by blocking NMDA, you actually cause downstream effects of increasing growth factors or increase the connections, right? Dendrite arborization that I talked about before. But there are risks for lamotrigine also, which I'm going to save for next week because I use lamotrigine a lot for bipolar depression, and lamotrigine is going to be like a 15-minute lecture by itself. But just know, NMDA antagonist, lamotrigine, Auvelity, ketamine, which includes Spravato and IV ketamine.
Mind if I can ask a question that'll clear up something from chapter 1 that I was just curious about recently?
What is the
For if you for these types of for serotonin and dopamine when they activate a G coupled protein, the book talked about how I know we didn't get deep into secondary and tertiary receptors or messengers,
Okay.
but the book talked about how you activate CAMP and then protein kinase. I just want to be clear, the action that happens in the postsynaptic neuron can be very diverse, right? It doesn't mean that there's like one set of things that happens. It can be all sorts of different things that's happening, which is causing these different side effects from all these subreceptors, right?
Yes, it's very complicated because one neuron, which I'm going to draw here, right, it's a circle, is innervated by millions of different neurons. It's not as easy as a presynaptic, postsynaptic. We make it that way for you guys to understand it. But what wins? It's going to be the summation of inhibition versus excitation, just to make it easier for you, right? So all these neurons are interconnected. So imagine if you're giving a neuron, I'm going to make it very simple, right? And it's being hit by a bunch of neurotransmitters that tell it to not secrete, right? Let's say 90% secrete, and it gets hit with receptors that say 10% secrete. What's going to win? The summation of the inhibition, right?
Right.
So that's why it's complicated. All these neurons are innervated, and it's going to be the summation of all the connections of GABA, glutamate, dopamine, whatever, hitting all these different receptors. And depending on epigenetics, right, your childhood adverse experiences, other meds that are on board, other substances that you're taking, right, are going to affect the effect of the medications. That's what we cannot really determine. Because remember, all these tests of the mechanism of actions are in vivo. They're not in live act, they're in animal models, in controlled environments, right? I'm curious. Yep. Good question. Yes.
I mean, I understand that like a glutamate can give you like a plus, like it makes you closer to firing, and a GABA will make you further away from firing or hyperpolarize the cell or whatever. But when you have these modulatory neurotransmitters that are acting on like downstream G coupled protein receptors, is it at the end of the day, are they only causing the postsynaptic neuron to either fire or not fire and just giving you more math towards that, or are they causing like much more complex downstream like proteins to be activated? They're doing all sorts of different things.
Because some of the G protein coupled receptors are just there for the cell to stay alive, right? For metabolism and keeping the cell structure, right? The glial cells around it, controlling the neuron so it doesn't wither away, right? Apoptosis, it prevents apoptosis. Going back to Marie, you talked about GSK pathway, right? GSK is one of the pathways that cause apoptosis. But you inhibit that with lithium, which we'll talk about next week, it helps with the cell not killing itself. It doesn't cause cell death. So all these pathways are important to know, but it's in theory, and clinical application sometimes is not that important, right? But in an academic sense, I'm teaching you guys, and if you're really interested, I can go deep about it. But let's save that for like the end when I cover all the material, and we can go into all the details if you really want to go to. So to make sure we cover everything so that I don't overwhelm people. Right? But these are great questions.
Yeah, I agree with what you were just saying. Thank you. I wanted to ask just because like there's a lot to say about everything, right? And like you were saying, you could go on and on about certain things. Are you going to be testing us on these off-label uses? Because it's like,
No, since this is an academic setting, I'm only entitled to teach you guys stuff that's on labels, and this is an academic setting. So I will not ask you off-label stuff. I'm prohibited from, right? I can't do
For
that.
example, like Wellbutrin,
Yes.
when it's used for depression, when it's used for smoking cessation.
Well, that's on label. Zyban was what we do. That's on label. Yeah, that's not off label.
That was my question.
That's
Yeah.
on label. That's on label. Yeah, of course. People are on Wellbutrin independent of depression, just for smoking cessation. But it's Wellbutrin SR, sustained release, not XL. Yes, Marie.
Can you go over half-life again? I didn't take the basic farm with everyone in the fall, so I was just curious.
So I know some people were confused with the questions. That half-life question was pulled as a definition from the textbook. I didn't write that question. That was just the definition question. But in layman's terms, a half-life is defined as how long it takes for half of the medication to leave the body. Half of the medication, half-life. That's it.
No, I meant, can you do the calculation for it? Like,
Times it by 5, an average. If something has a half-life of 12 hours, the steady state will be 60 hours. If something has a half-life of a week, it will be 5 weeks.
okay, so you just times it by 5. You don't break it down like half, 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 half. Okay.
Yeah.
Thank you.
So you know washout and you know how long it takes to hit steady state, right? In general, we don't really, unless we're trying to load a medication, we don't really try to increase it faster than the half-life, because then what's going to happen is the patient might have more side effects because their body's not adjusting to the half-life, right? In general. But there could be occasions, inpatient, where your patient's really aggressive and you're going to increase the med faster because of safety, right? But in general, we tend to follow that rule, right? Let a med hit steady state first before you adjust the medication. But that could always be broken. The point I'm making is that there's a lot of rules, right? There's the art of psychiatry, which eventually you guys will get to, and there's the science of it. My job here is to teach you the science of psychiatry, right? Once you know the rules, you're free to break it, right? I break a lot of rules in psychiatry. That's what makes me a great practitioner, because my patients love me because I know when I can break it and when I can't, right? Because I know the science behind it. But if you're only stuck following algorithms, you don't know the details, you're just going to follow algorithms. What if a patient comes to you and they follow all the different algorithms that you've already followed? What are you going to do with them? Right? You're stuck. And if a patient comes to you with a med list of like 5 meds and you don't really know, well, the diagnosis is there, GAD, MDD, they're on Buspar, but they're also on Aspari. Well, Buspar is FDA approved for GAD. Trazodone is FDA approved for insomnia, so I guess I'll keep it. But just because they're both FDA approved for the med doesn't mean you keep it, right? Because you're doubling up the mechanisms of action. What's the point of that? You're giving them more meds, more strain on the liver, right? More risk of side effects. Plus the inconvenience of having to pay a copay for a med that's not even needed. Right? I hope I get my point across, but that's why this is important. Other questions? So any med that's a 5-HT1A, right, agonist, or 5-HT1A antagonist, in theory, could increase the rate of response of antidepressant, right? There were some studies, even though, some studies say yes, but initially there was an idea that the reason why vilazodone came to the market was that if we give someone SSRI and we give them a very specific 5-HT1A partial agonist, let's see if we can downregulate that autoreceptor faster, right? And there was some studies that showed that maybe some patients did respond maybe a week earlier. So even if you respond a week early, it was worth it for you to take vilazodone, right? Because a week of extra depression sucks. So if I can take vilazodone, there's studies that show that my depression will get better in 4 weeks instead of 5 weeks, why not try it, right? And the science behind that is that the partial agonist, the component of it, is downregulating the 5-HT1A autoreceptor at the presynaptic neuron, right? Does that make sense? Because the partial agonist is working as a way to kind of downregulate that receptor by agonizing it. You're saying, why am I agonizing the receptor then? It's a brake. Why am I stepping on the brake? Because if you step on the brake long enough, it's going to downregulate and desensitize and turn off. Then you have no brakes. And then that presynaptic neuron is going to fire serotonin as fast as it can, right? Hit the 5-HT2A receptors, right? And hit all the other receptors, and maybe the patient will do fine on it. And it's okay. We see that too. But if they have symptoms like, hey, I love the Prozac you gave me, but now I'm just having issues with falling asleep. Trazodone, 50 milligrams at bedtime. My appetite still sucks, and I get really bad nausea from that, but I love it. It's been helping me. I don't want to stop it. I just have really bad nausea, and I can't sleep at night. Mirtazapine. See how you're matching the clinical profile of the receptors and the quote unquote side effects to your benefit? It's not necessarily a side effect is not necessarily a bad thing, right? Because there's sometimes side effects we can leverage. Because if a medication is sedating, if then the side effect is sedation, I don't mind giving that med to you if it's at nighttime because you're gonna sleep better anyway. What's the difference, right? Yes.
So just to understand, so it's considered upstream if it's going to downregulate the autoreceptors and downstream if it's going to
I'm
for
not gonna ask you about
synaptic
upstream
plast.
and downstream. Don't worry about that.
Oh, you're not. Okay, so just know that for like synaptic plasticity that when you about with the downregulation of the autoreceptor and then upregulation of the BD and F.
Correct, yeah. Just know that how we use upstream and downstream in psychiatry is similar to like how we do it in like medicine, right? If someone has uncontrolled blood pressure for a long time, right? The downstream effects are what? Liver injury, kidney injury, right? Due to all those downstream effects, right? But you want to help it upstream. So for instance, if someone has first episode depression, I want to treat it upstream first by treating it right away, either at the glutamate level by giving an NMDA antagonist, right? Or whatever it is. But you don't want it to persist. Because once it goes downstream, low self-esteem, maybe panic attacks might come because they get anxious that people they're depressed, right? All these other outcomes can happen from that, and that will be the downstream effects, right? The more upstream you treat something, the better the outcomes, right? Which is leading to the root cause of the illness, which we don't have right now in psychiatry, right? We don't really know. Is it childhood abuse? Is it too much cortisol? I'm doing you guys a favor. In the other classes, I tested you on the causes of depression. I'm not gonna do that. I want you guys to assume that depression is there, right? What are the treatments? We're gonna focus on the pharmacology about that. You don't have to know the patho because there's enough for you guys to know already. So I'll give you guys that break. But there's also implications for inflammation, right? As we know, chronic inflammation is not good for depression. So a lot of times what I do is I check a C-reactive protein for patients who have treatment-resistant depression. If CRP goes up, that's a sign of inflammation. I try to get them on a good diet regimen. I substitute their, if they do a lot of like canola oil, I switch it to olive oil. I put them on the Mediterranean diet if they're open to it. It's more than just medication. Exercise, try to reduce the inflammation. All right, but that's just advanced stuff. But take that as you will. Yes.
What advice would you give to somebody who's, let's say, they're waking up at 3 in the morning and they can't go back to sleep, something like that? Is that related to the inflammation cycle too, and acetylcholine?
That's a tough. Insomnia is pan-diagnostic. It could be due to anxiety. It could be to nightmares and PTSD. It could be from depression. I'm gonna do a separate lecture on sleep disorders by themselves. So let's hold that for now because
Oh, perfect. Thank you.
Aaron.
Haven't they done studies on depression and anti-inflammatories?
There have been the lead hypothesis now for depression is that it's heterogeneous, right? It has multiple causes, but the pathway is the same. The best example I can give you is like a sneeze, right? You can have a sneeze from allergic rhinitis. You can have a sneeze because you have a brain tumor, right? But we don't see it. So that the reason why is that even though anergia, low mood, suicidality, poor appetite, all these symptoms we think is depression, but it could be multiple pathologies leading to the same phenotype, right? The same symptoms. So we're not really sure. There are some people that respond to serotonin reuptake inhibitors. There are people that respond to non-serotonin reuptake inhibitors, but their symptoms are very similar. So maybe their depression, quote unquote. Because remember, the DSM was not a good tool, right? There's no like biology markers. You don't have to do. There's no blood types. It's more subjective symptoms from the patient, right? I feel this for this long, and I felt this for that long, and you're making diagnosis based on that. But again, as you know, there's a lot of issues with that because the patient is a poor historian. You might miss some symptoms, right? And you have to round out. A lot of times you have to give the best diagnosis based on rounding up information. It's called uh, uh I can't think of the word. But if someone was like coming with a bunch of symptoms, right? You have to give a diagnosis, you have to build the insurance. People don't meet those symptoms right away. So you have to kind of, with the best of your ability, give them a diagnosis, which is a differential. This looks like depression, but my differential is bipolar depression, and there also could be some GAD there, right? And I'm going to keep interviewing that patient and formalizing my diagnosis based on getting to know that patient better and obviously treating their symptoms, if that makes sense. It's called a from Frost presentation. From Frost. Yes.
What would you do if you had a patient who came in with symptoms of depression and then let's just say they're like comp gene didn't metabolize dopamine, so they have a low dopamine, but they have a family history of schizophrenia. What do you do then? Because I know you said with a lot of the different medications you have to be careful.
So all these things are part of your formulation, right? You write down what are the risk factors, and I do this with patients. See what I'm writing now with you guys' notes? I write this down from the patient, but I write like your history, right? You have a history of this, I write that, I write the meds, and I write some side effects, and we go over it together. I let them keep it too. Hold on to this because this is our game plan, right? Look at it over. You don't even have to decide what med you want to take right now, right? But I'll write the 2 names of the meds that I want them to look up online, right? It might be counterproductive because they'll go on Dr. Google and look stuff up, but it's okay. I want them to, so we can talk about it together. And then we decide together what is the best treatment for you. There's never going to be zero risk, right? There's always going to be some risk. I could give you Wellbutrin, but it's a family history. But you don't want sexual side effects, you don't want weight gain. So maybe we can do a low dose. If you start feeling some paranoia, you start hearing things that aren't there, you start having some weird thoughts, stop it and let me know right away, right? Then we'll abandon ship right away.
Would you ever give a partial agonist? I was just curious about that. Would it in one part of the brain work as an antagonist and in the other one work as
is one of the top prescribed atypical antipsychotics for a reason. It's a partial agonist. It's one of those meds that, if you're not sure, you could use it, but it also has its down effects too. You could. When you go to schizophrenia, you're gonna get all the details. We're gonna talk about Abilify and all these meds. Trust me. A lot of you. I consider myself an expert in schizophrenia. I did it for many years, and I treated a lot of patients that couldn't be stabilized by a lot of other doctors. So I take a lot of pride in stabilizing them. So I'm going to give you the ins and outs of all the antipsychotics. We'll talk about that in detail. Yeah.
I'm actually very excited because a lot of people, you always say that you use lithium, and a lot of people don't like to use that, and they misdiagnose when you have a mood disorder for something else. So I'm excited for that lecture. So
Any
thank you.
medication is dangerous, right? You have to educate yourself on what the risks are and use it appropriately, right? You give a 5-year-old a hammer, it's dangerous, right? You give it to a carpenter, it's not dangerous, right? Lithium at low doses can be life-saving for somebody. I've had some patients on lithium and I've never felt this way before. I'm not suicidal anymore. I've been suicidal my whole life. Low dose lithium could be, of course I have to check the thyroid functioning, the kidney functioning. Of course, there's always risks, but listen, if you don't want to prescribe lithium or clozapine, don't do psychiatry. Be an expert type. That's a joke, but Joseph.
Can I take a stab at Thomas's question in the chat real quick about autoreceptors versus heteroreceptors, and just tell me if I'm being wrong or not? So I understand that
are the brakes. They're a negative feedback loop. So if I say something is an autoreceptor, it's on the presynaptic neuron that's going to stop the further release of the presynaptic neuron. A heteroreceptor is another receptor that's not the same as that neuron secreting. So a neuron can be secreting serotonin, a neuron can be secreting dopamine, right? But the receptor that's on it is not the same receptor that's spitting out. It is a separate receptor. Like
as a rule, are there more autoreceptors or heteroreceptors on a given neuron?
I don't know the answer to that. Actually, that's a good question. I'm not sure. Yeah, I don't know if it's more. I guess I'm assuming it's probably based on genetics and the person's life experiences. Same as all the other receptors. Yeah.
So when we were talking about the autoreceptors for serotonin initially creating a decrease in the amount of output for serotonin, and then you upregulate the autoreceptor, and then eventually you catch up and produce more.
No, you're not going to upregulate. You're going to downregulate the receptor.
You're going to downregulate. Sorry, you're going to downregulate the autoreceptor because sensing serotonin is going to produce less, so you're going to downregulate. Is it so it's the opposite for dopamine, right? Because if you're giving a D2 antagonist, you're gonna sense that you're gonna produce more dopamine, and eventually you're gonna start producing less.
Say that again. I'm sorry, we're talking at the same time.
So I'm just wondering if it's the opposite for the way that a dopamine antagonist would act on the autoreceptor. So if you're gonna give a dopamine blocker, a D2 antagonist, it's going to attach to the autoreceptor. That's going to make you initially create more dopamine, and then it goes backwards the other way.
Which is why sometimes patients can be stable on Haldol for many years, but you're chasing that by trying to adapt to the brain adapting to it, right? So someone stable on how they'll attend, those receptors over time are gonna upregulate. I was so used to this much dopamine secretion, I'm gonna upregulate and become more sensitive, right? So you're like, well, raise your Haldol now to 15. You block those receptors, the brain's like, oh, that's you're gonna keep escalating.
Is that
It's a tolerance response then, which is working the opposite way for this one that we were talking about today with the serotonin.
what tachyphylaxis is?
That's another way of saying tachyphylaxis as well. Yeah. With the receptors adapted to the meds that you're giving them, and either we do a drug holiday or we switch the mechanisms to kind of get you to respond to it again. Yeah. Tachyphylaxis. Yeah. In the Since Valentine's Day, think of like your crush, right? You want to buy them chocolates every day. What's gonna happen? They get away from me. I don't want to talk to you. They're gonna run away and they're gonna be less sensitive to you, right? If you play hard to get, that's the way to do it. I'll go another 5 minutes since we started late. I know there's a lot of information, so I'll let you guys process it. I don't want you guys to think I'm not trying to sabotage you guys, right? I hope you see from the first exam, I made questions there that answered the other questions, right? On purpose. And I also made it so you could go back on purpose too. I normally don't do that. So that was tests for me are a way to reinforce learning. It's not a way to punish you. But you'll be punishing yourself if you don't know the material. I'm not punishing you. You're punishing yourself, right? So if you know the material, the test will be a reinforcement of the material you know already, and it will help you reinforce that. So I'm not trying to fail. If you guys listen, if I'm not committed to this, it's freaking February 13th. I'm married, I have kids. My wife is waiting in bed right now, probably in lingerie for me. I'm just kidding. Maybe not. I don't know. I'm staying here till 10 o'clock talking about receptors for you guys. That's something that I want to do. You think I really want to do this? I enjoy it, but it's the day before Valentine's Day. Come on now. If I was a jerk, I wouldn't be doing this. All right, just something to think about. Please read. I'm here to help. If you have questions, email me. We'll meet one-to-one if we have to. I want you to absorb the material. All right, but enjoy your Valentine's Day. Don't take your Paxil. Take your Wellbutrin. All right. Have a nice weekend. Take care. Bye.
You too.
Thank
Have a
you.
great weekend.
you.
Thank you.
Professor. Have a nice weekend.
Have a great weekend.
Thank you.